Get us started. Gonna just get a thumbs up if you can see the reading from the same chart slide. All right, great. All right, well, good morning, good afternoon, wherever you are. I was asked to open our conversation this morning, and I'd like to begin with a question that I suspect many of us are asking. What place, if any, should artificial intelligence have in healthcare chaplaincy? It's a big question, and I don't think it has a simple answer. My hope this morning is not to answer it for us, but to help us get our bearings together before we set out to explore it in earnest. If you'll allow me one metaphor, the Odyssey seems to be having something of a cultural moment. And while I promise not to ask anyone to sail past the sirens or to outwit a cyclops, I do want to offer the one thing that every voyage depends on, which is a reliable chart. So perhaps it's best to think of our time together less as a keynote and more as the small "you are here" marker on the map. Without one, we tend to assume that we are all traveling the same route, right up until the moment we discover that we've been reading from very different charts. Sounds like we've got some background noise there. I don't know if we can silence that. Thank you. That, in fact, is something I've noticed over several years of thinking and writing about AI and chaplaincy. When these conversations become difficult, and they often do, we're usually not disagreeing about AI at all. We're working from different understandings of chaplaincy itself, from different assumptions about how a chaplain is formed, what spiritual care is meant to accomplish, how our profession demonstrates its worth, and what pressures it's under. Those assumptions, often without our noticing, shape where each of us imagines that AI belongs. So before we ask where AI belongs, I'd like to spend a little time getting oriented to the landscape, charting the coastline, so to speak, before we debate the route. We may not all choose the same course in the end, and that seems entirely appropriate. It simply helps if we're looking at the same map. So here's the shape of the map as I've come to see it. You can see a single line. At one end sits supplementation, by which I mean AI that helps the chaplain do the work. At the other end sits substitution, AI that does the work in a chaplain's place. Nearly everything people have in mind when they speak of AI and chaplaincy falls somewhere along that line. And nearly every disagreement in a conversation like this one is, at heart, about where on the line a particular use belongs. I'll call that line the continuum, and we'll return to it more than once. I want to offer 4 bearings before we come to AI itself. How chaplains are actually formed, what our field has come to count as success, what's shifting underneath the profession, and where along that continuum AI has already arrived, which I suspect is farther than many of us realize. I'll hold my own views lightly and save them for our discussion, since this morning is meant to be a map rather than a verdict. What follows is a scan across peer-reviewed research, professional documents, and practitioner writing, rather than a systematic review. Where the evidence seems strong, I'll say that, and where it seems thin to me, I'll also try to note that as well. So let me begin with the pipeline, since it's the part that people outside our world most consistently misunderstand. If you're not a chaplain, you might picture one as a member of the clergy who happens to visit hospitals. That's not quite what a board-certified chaplain is. In the United States, a board-certified chaplain has usually completed a graduate theological degree, 4 units of clinical pastoral education, 2,000 hours of practice, endorsement by a faith community, and a formal certification process. Taken together, that's commonly 6 to 10 years of preparation. The heart of it is clinical pastoral education, and CPE is a peculiar and demanding form of learning. A single unit runs 400 hours, though the hours are not really the most interesting part. It's the method that's the most interesting. You go to the bedside and then you return and write down as nearly word for word as you can what happened in that room. That document's called a verbatim, and you bring it to a small group of peers and a certified educator who examines it and examines you with a directness that most professional education never approaches. The group asks what you said and why, what you were feeling, and what you found yourself avoiding, and what the encounter did both to the patient and to you. This happens again and again, over a year or more. It's not at its core a transfer of information. It's closer to a supervised form of self-confrontation in the presence of suffering. The pipeline does not exist to fill a person with content. It exists to form a person's judgment in the presence of suffering. The credentialing bodies rest on top of that formation. Among them, the Association of Professional Chaplains, the National Association of Catholic Chaplains, Neshama, the Association of Jewish Chaplains, and the Spiritual Care Association, to name a few. How does a body decide that you're ready? Largely through the same kind of reflective practice that we just described. The APC, for instance, asks you to submit written materials, including competency essays and verbatims, which a committee then reads and discusses with you. It is, in a sense, the verbatim grown up. You demonstrate your formation on the page, and colleagues who have walked the same road judge whether it's truly there. The requirements themselves continue to change, and they are all not moving in the same direction. For example, the National Association of Catholic Chaplains once expected something like 72 credit hours of graduate theological education, and now it asks for 32. The Association of Professional Chaplains no longer requires the Master of Divinity specifically, though it still expects 72 hours of graduate study, arrived at by a path convoluted enough that I'll spare you the details this morning. And the Spiritual Care Association has moved in the other direction entirely, raising its requirement from 2 units of CPE to 4. So taken individually, these are modest changes, and I wouldn't read too much into any single one of them. What interests me is the argument underneath them. The Spiritual Care Association has argued in its own published rationale that the traditional requirements, whether a graduate degree or a given number of CPE units, has never actually been shown to predict whether someone will become a competent chaplain, which is part of why it has built its certification around competency testing instead. Our field, in other words, is presently arguing with itself about what genuinely produces a good chaplain. And here, already before we have reached the part of the talk that's supposedly about AI quietly enters. Consider how 2 of our certifying bodies test competence, since they do it quite differently. The APC path rests on written materials that a committee evaluates. The SCA path asks you to sit down and demonstrate spiritual care with a simulated patient, a trained actor, while assessors observe. A capable language model can already produce the sort of written reflection the first path leans on, and produce it well enough to give an examiner pause. Yet no language model, as far as I know, can sit with a simulated patient and be present in the way the second path requires. The same technology that might slip through one gate cannot come near the other. I would ask you to keep that picture in mind, since it's a small preview of what follows. So the first bearing on our map is this: chaplaincy is not a volunteer visiting. It's a credentialed clinical profession with a long and unusual formation pipeline. And that pipeline exists to produce something quite specific, namely the formed judgment of a person who has sat under supervision in the presence of suffering. When we ask later which parts of this work AI might take on, that formed judgment is precisely the thing we'll be deciding whether to supplement or to substitute. The second bearing is, to my mind, the largest internal story of the past 25 years, and it's a story about evidence. For most of its history, chaplaincy described itself in terms of what it did. We visited patients, we offered presence, and we provided spiritual care. All of that was true, and nearly all of it was very difficult to measure, which became a problem the moment the rest of healthcare began measuring almost everything. So the field pivoted. The shorthand you'll often hear is volume to value, a movement from describing what chaplains do toward demonstrating what chaplaincy accomplishes in terms the institution recognizes. Consider the state of that evidence. A decade ago, Pesut and colleagues reviewed the literature and found most of it descriptive. Chaplain involvement was associated with greater patient satisfaction, but one could not yet say with confidence which specific interventions actually made the difference. The field has not stood still since, and later reviews document real maturation. Even so, one conclusion keeps returning. We have considerably more evidence describing what chaplains do than we have rigorous evidence isolating which particular things we do produce which particular results. And we're not even of one mind about whether we should pursue that second kind of evidence. Damon and colleagues put the worry directly in the title of a paper, asking whether outcome research can respect the integrity of chaplaincy. That question names a real tension between proving our worth in the currency the institution accepts and protecting something in this work that may be diminished when it's turned into a metric. I raise this because it tells a good deal about where AI fits. The stubborn gap is not a gap in chaplaincy's practice. It's a gap in our capacity to observe and analyze that practice at scale, which happens to be exactly the sort of gap that computational tools, including AI, are good at closing. Natural language processing might surface patterns in chaplains' own notes that no one has the hours to read for by hand. Analysis of referral patterns might show us who's being missed. Better instruments might be built more quickly than any single team can manage. In each case, AI could help our field move from merely describing its practice toward genuinely learning from it. Notice, though, where all of this belongs. It sits at the supplementation end, nowhere near the bedside. This is a claim about research infrastructure, about seeing our own work more fully, and not a claim that a machine can do the relational work the research is trying to measure. I would gently ask us to keep those two apart, since much of what follows depends on not confusing them. The third bearing concerns the ground beneath the profession, which is moving in three ways that are relevant to this conversation. The first has to do with whom chaplains are actually serving. By the middle of this decade, roughly 3 in 10 American adults described themselves as religiously unaffiliated. Chaplaincy has felt the shift directly. In the first nationally representative survey of its kind, close to 1 in 5 Americans reported having interacted with a chaplain, and among them, about 27% claimed no religious affiliation. It's worth being careful about what that figure means, since it reflects only how people describe their own affiliation. It's not evidence that spiritual care has become a secular enterprise, since about half of the unaffiliated tell Pew that they are at least somewhat spiritual. The more consequential point is that chaplaincy has become substantially interfaith and is increasingly asked to accompany people who claim no religious affiliation at all. Wendy Cadge offers a framing I've found clarifying. She suggests that for generations, the congregation was the way spiritual life was delivered in American life. That delivery system has weakened, and yet the need has not gone away. It has simply moved more and more into the hospital. This is part of why the hospital has quietly become one of the primary places where the spiritual life of this country actually happens, and the chaplain is often the person standing there when it does. The second shift concerns who else needs care. Burnout among healthcare workers has come down from its pandemic peak, but it remains serious, with some studies still reporting rates above 50% among clinicians. As a result, chaplains increasingly care not only for patients and families, but for staff, leading debriefings after a difficult death, checking in with a unit after a brutal week, and tending to resilience and moral recovery. Supporting the healthcare team has become one of the fastest growing parts of our work. The third shift concerns money. Chaplaincy is persistently regarded by administration as something nice to have. Departments are cut, even in institutions with whole person care commitments and joint commission expectations around spiritual assessment. This precarity is not incidental to our topic. It's the backdrop against which everything else is argued. Two particular arguments grow out of it, and both will return, so let me underscore them now. There's the efficiency argument, which holds that we might deliver the same care with fewer people and less expense. And there's the access argument, which holds that there are simply not enough chaplains to reach everyone who needs one. I'd ask you to hold both of those in mind. Put the three shifts together and you have a profession facing rising and increasingly diverse demand, a widening role that now includes the care of staff, and real financial vulnerability, all while under pressure to prove itself. That is precisely the kind of opening into which a new technology tends to move. To stay with our metaphor a moment longer, it's less a gentle breeze than a current, and it does not push toward the cautious supplementation end of our continuum. It pulls toward the far shore, where the promise is to do more with fewer chaplains. That current, I think, is the one this talk is swimming against. Which brings us to the fourth bearing and to the reason we've all gathered. I want to lay this out along the continuum, supplementation at one end and substitution at the other, because AI and chaplaincy is not one thing. As we walk the line, I would suggest keeping a single question close at hand for each use we consider. Is this helping a chaplain do the work, or is it doing the work instead? At the near end is the quiet behind-the-scenes work in the cubicle rather than the bedside. Let me make it concrete. A chaplain finishes a visit, and rather than spending the next 20 minutes typing, speaks a few notes into a HIPAA-protected device that drafts the chart entry, notes that the patient asked for a Spanish-speaking colleague, and returns the one thing there's never quite enough of, which is time to be in the room. Documentation, scheduling, translation, workload mapping, and research support all live here. Clarisy and colleagues survey this whole range and are careful to describe it as free in a chaplain's time rather than replacing a chaplain's judgment. In most rooms, this is uncontroversial. Supplementation is a fairly pure form, or supplementation in a fairly pure form, with a chaplain firmly in place. A step further along is screening and case finding. And here the research becomes really interesting. In 2025, Masukawa and colleagues trained machine learning models to identify spiritual and psychological distress from the free text already sitting in the medical record, drawing on more than 1.5 million records from the final month of life of some 800 patients. The best model performed strikingly well, and among the words most closely associated with distress were some of the plainest imaginable, words like want, me, and how. So I want to be careful here, since this is exactly the sort of finding that gets oversold. These are retrospective single institution studies. They show that machine learning can find signals of distress in texts that clinicians have already written. They are not deployed systems validated to detect spiritual distress reliably across a whole hospital. What they point toward is a direction. One of the most immediately practical uses of AI may simply be helping us find the patients who need a chaplain in the first place. In one small study, chaplaincy professionals described using AI to comb through record data and patient messages to surface people who slip through the usual referral cracks, and one hospital was already using such a tool to route people towards spiritual care. I offer this as my own reading rather than a settled finding, but AI-assisted case finding may well be the least controversial and most useful application in the whole landscape. The chaplain is not substituted and is not asked to make the spiritual assessment. The machine does what it does well, reading patterns across enormous amounts of text so that a human being can do what only a human being can do, which is to offer care with the specificity, nuance, lived experience, and embodied presence that no model possesses. We remain comfortably at the supplementation end of the line. Now the line begins to bend. Further along, we find consumer-facing spiritual chatbots, which operate largely outside institutional chaplaincy and are available to anyone with a phone. Some are explicitly religious, some are grief companions, and some are broader mental health companions. What they share is that they sit almost entirely outside the structures that govern healthcare chaplaincy. No credentialing body reviews them, and the App Store never asks whether the developer has completed a single unit of CPE. Here, the machine is no longer handing a patient to a chaplain. It's meeting the patient directly. Danielle Taminio Hansen, a pastoral theologian at Emory University, tested 4 denominational AI chaplains from her own hospital bed after an accident, and her verdict was careful. The theology was accurate enough, she found, but what the tools lacked was specificity, nuance, lived experience, and embodied presence. I'd ask you to hold on to that list, because it's the first time today that we hear from someone actually lying in the bed exactly what goes missing as we move toward the far end of the line. Nearby are clinically adjacent virtual agents, older and more modest than headlines suggest. A decade ago, in a small study of a scripted palliative care agent, older adults proved surprisingly willing to discuss end-of-life planning with them. This is not proof of anything about outcomes, but it is a quiet hint that people were more open to the machine and earlier than we might have assumed. The willingness appears to be real, and what it means is still an open question. And then the line makes its sharpest turn. At the far end sits substitution itself. AI intended to take over functions traditionally performed by chaplains. Aaron Fuller has described a research project for trauma nurses that proposed AI chaplain avatars to provide spiritual care where no human chaplain would be present. The project was suspended after chaplains raised ethical and professional concerns. I mention it not to alarm anyone, but because it marks the frontier quite precisely. It was not a thought experiment. It was an actual proposal developed within the last 2 years. So there's the coastline laid out from one end to the other. And let me say a little bit about what the research community makes of it, offering the range rather than a verdict. The field has also settled on some useful vocabulary. Eric Stoddart asks whether AI or artificial pastoral care is best understood as abdication, delegation, or collaboration. He rules out artificial care in which the machine becomes the caregiver, while leaving room for AI-assisted care in which the machine helps a human being who remains the caregiver. His 3 words in the end are really our continuum, dressed in other clothes. A pattern also runs through much of this literature. A moment ago, I said that our field argues with itself, and now I'm about to say that there is a consensus. Both are the case. In the published literature, the stated consensus is to supplement rather than to substitute, even though many chaplains in the room feel something closer to rejection. What strikes me is that even the optimists hold the line. Clarisy and colleagues who are genuinely enthusiastic about what AI can do still write that its dialogue is the output of a language generator rather than an encounter with the transcendent, and that spiritual care involves a relationship and an uncertainty that make it imperfect, and for that very reason, human. The conviction that something human is essential here is not only the skeptic's conviction, it is voiced by the very people building the case for AI. This brings me to what I find the most interesting territory of all, which I've come to think of as the empathy paradox. It has 3 parts, and I believe we need all 3 because taking any one of them alone is how this literature can get misused. The first finding is that people frequently rate AI-written responses, the text an AI produces in reply to a patient's question, as more empathic than responses written by humans. In one study in JAMA Internal Medicine, clinicians judged chatbot answers empathetic roughly 9 times as often as physicians' answers. And in other experiments, evaluators rated an AI as more compassionate than trained crisis line volunteers, even when they knew which responses were the machines. The second finding complicates the first because when people are free to choose, they tend to prefer empathy that comes from another human being. Identical AI responses labeled as human were rated more empathic than the same responses labeled as AI. And a third shows that people will choose human empathy even when they rate the AIs more highly, reaching for the person even after judging the machine's response to be the better one. These are findings about perception and preference, not about care delivered at a bedside. And I don't intend to resolve them today. I would only add that any argument about AI and chaplaincy that reaches for one of these 3 findings while setting the other 2 aside is not being fully honest. There is, encouragingly, more real research here than many of us realize. When a Nordic team invited 18 university chaplains to build AI chatbots themselves and then reflect on the experience, they named 4 things the tools could not quite do: listening, connecting, carrying, and wanting. 2 of those are really interesting to me. The machine cannot carry, in the sense that it cannot be weighed down alongside a suffering person. And it wants too much. It's too eager. It's quick to fill a silence, quick to resolve, too quick to fix. The authors give the missing quality a name, attunement, by which they mean the capacity to be tuned to another person's inner state, to sense what they're feeling, to stay with it, and not rush them anywhere. It's the difference between a response that's merely correct and a presence that's genuinely with you. One practice model has stayed with me. It's called the human audit, and the idea is disarmingly simple. We let the AI draft the skeleton, the outline, and the first pass, and we let the chaplain add the marrow, the discernment, and presence that turn a document into care. There is also an honest gap, and it's a large one. As of this year, there is essentially no peer-reviewed research on what AI means for how chaplains are formed. I want to give that a moment because I think it's important. I think it's an important thing that's missing. The very part of chaplaincy on which I spent the first third of this talk and really my whole professional life, the formation of a chaplain, is the part we understand least when it comes to AI. There's no large-scale survey of chaplains' attitudes, very little on what patients actually prefer, and no head-to-head study of AI-assisted care against human-only care. There is a certain irony worth sitting with. A profession that spent 25 years teaching itself to ask for evidence is now being asked to make decisions about AI with almost none. And the emptiest region of the map lies directly beneath the far end of the line where the stakes are the highest. So let me gather the four bearings into a single view. Chaplaincy is a credentialed clinical profession with a long and unusual formation pipeline. It's in the middle of a demanding pivot toward proving its value in measurable terms, even as it argues with itself about whether that pivot distorts the very thing it's trying to measure. It faces rising and more diverse demand, a widening role that includes the care of staff, and a persistent financial vulnerability. And into exactly that situation, AI has already arrived, all along the continuum, from documentation at the near end to at least one proposal for outright substitution at the far. The stated consensus is to supplement rather than to substitute, though many chaplains' first instinct is to reject the whole enterprise, and I understand that impulse. The evidence points in both directions at once. Since AI can produce empathic cues that people rate above our own, and yet people still choose the human. And the research that might most help us decide, above all on formation, has not yet been done. So let me end more or less where I began. The question was never really whether AI belongs in chaplaincy, because it's already here. From the documentation at the safe end of the line to the avatar at the far end that would stand in a chaplain's place. The more honest question is what we intend to do about it. Here I will step just slightly past the map. I've become increasingly convinced that our task is neither to deny that AI exists, nor to wait for it to be done to us, but to take part in the conversation about it as we are today. There may be good reasons for each of us to learn these tools firsthand, to sit down with something like ChatGPT or Claude and see for ourselves what they do well and where they fall short. There's good reason, too, to find out how our own hospitals and health systems are already integrating AI, since I think we will find that they already are. And there's good reason to be present in the rooms where those decisions are made, not only as the colleagues who raise objections at the end, but as the ones who help shape the course from the beginning. It's worth remembering how our profession has met technology before. I've sometimes spoken of the telephone, the overhead pager, the electronic chart, and the video visit, as though chaplains decided about them. And that's not quite right. In fact, those changes largely happened to us, and we adapted to them, and we're remarkably good at adapting. It is one of the real strengths of this work, this ability to meet whatever comes through the door. Adapting, however, is not the same as steering. And this time, perhaps, we need not simply wait and adjust. This time, we may be able to help drive. And I would hope that we make our decisions about AI neither out of fear nor out of enthusiasm, but out of a clear and honest understanding of what this work actually is, and of the one thing formed over all those years in the presence of suffering that no machine has yet been shown to carry. Whether AI finally proves to be an assist, an adjunct, or an adversary is genuinely still open. And that's what the rest of this conversation is for. I hope that what I presented levels the field so we're all standing on the same ground first, reading from the same chart, which leaves one question on the map that no technology can answer for us. And that is not what is AI for, but what is chaplaincy for?